Well, thank you very much. It is my absolute pleasure and thrill to be able to have the opportunity to speak in front of this group today in what I think is going to be really exciting, interesting and discussion over the next 2 days. And I'm certainly looking forward to hearing how the discussions develop. So I was asked by Jennifer to sort of get the ball rolling and to talk about an introduction to APS-1. And so what I thought I would do to try to set the scene is to describe a story or how one family's experience was with this condition. So the family I'm going to talk about was the boy who was affected, first presented at 5 years of age. This family lived in a rural country town. It was about a 5-hour drive from the nearest paediatric tertiary centre. And at 5 years of age, the boy presented with a hypocalcemic seizure, so low calcium. And this was found to be secondary to insufficient amounts of parathyroid hormone being produced, or hypoparathyroidism. This was understandably a very scary time for the family, but the child responded well and was sent home on oral medications. However, unfortunately, only 6 months later, he represented to the local hospital extremely unwell, with low sodium levels in his blood, and with decreased responsiveness in adrenal crisis. And the diagnosis of adrenal insufficiency, or Addison's disease, was then made. So within 6 months, this family had gone through the experience of 2 very scary and potentially life-threatening episodes, and this was obviously very difficult for them. The local, the team who'd been looking after him did recognise this link between hypoparathyroidism and adrenal insufficiency and made the clinical diagnosis of APS-1, and this was confirmed on genetic testing with a positive AIR gene mutation. However, going forward, life got a little more complicated. So between 6 and 8 years of age, this child started developing problems with his teeth. So he had some dental enamel hypoplasia, which required lots of dental visits. He unfortunately lost all of his hair and had significant alopecia, and started developing recurrent episodes of candida, particularly in his mouth, which were really difficult to treat. 9 years of age, he started developing chronic diarrhea, which was extremely difficult, caused him to have to miss lots of episodes of school. It also, in particular, made the management of some of his other conditions very challenging. He needed recurrent stress dosing of his hydrocortisone, which led at times to him putting on a lot of increased weight. His calcium levels would swing from high levels to low levels, with often a lot of symptoms when the calcium levels went low. And really his quality of life at this point in time was really challenging to try to maintain in a good state. So he was subsequently diagnosed that what was underlying this chronic diarrhea was that he had both pernicious anemia and autoimmune enteropathy. Meaning that he was really having difficulty in absorbing these medications across the gut. 15 years of age, he was finally, because of really very difficult to manage calcium levels, was commenced on immunosuppressive therapy, which really improved his quality of life. His calcium levels were much more stable. He didn't have the diarrhea anymore. However, unfortunately, he developed a complication from the immunosuppressive therapy with high blood pressure and had to be changed on agents. So I think this case, to begin with, really demonstrates the complexity of this disease, both at a medical level and also for the impact on a family. In addition, he has a younger brother, and this younger brother also was positive for the AIR gene mutation. But because they knew, he was subsequently diagnosed with both hypoparathyroidism and adrenal insufficiency, but without coming in with a hypocalcemic seizure or an adrenal crisis, as they were able to monitor him. He did develop mild oral candidiasis and enamel hypoplasia, but did not of note develop any of the alopecia, the hair loss, or any of the GI symptoms. So if we think about this family, we have here illustrating the complexity in the medical presentation. The amount of time that this family had to invest in managing and trying to provide care for their child, frequent blood pokes, having to travel long distances to have frequent appointments. But it also represents the spectrum of this disease. So these two boys have exactly the same gene change that's underlying their condition, and yet one child has very multiple systems affected, and the other child has predominantly just two major systems affected. So what I'm going to have been asked, and what I would like to, in the next 15 minutes or so, talk about today is to give a very broad stroke outline of APS-1. And obviously over the next 2 days, we're really going to get into a lot more depth about some of these individual aspects, but we're just going to do a very brief overview. So I'm going to briefly talk about some of the clinical presentation, to review what the underlying pathophysiology is, and again, chat about some of the challenges and opportunities we have in the management of this condition. So if we look back and try to think what's one of the earliest reports that we have about a child where they think probably had APS-1 was from 1929 in the US. So these doctors, Dr. Thorpe and Hanley, described this case of a 4.5-year-old girl who presented with chronic tetany, so muscle spasms from low calcium levels. And they note that this coincided with the appearance of a chronic oral infection, which they thought was Candida. So I think this case, even though it's from the 1929, reflects, again, some of the challenges in this condition. This graph here demonstrates the swinging in the calcium levels, where the solid line is over here is the calcium levels, and where the little crosses are times when this little girl had symptoms with her calcium. Apologies. So like what sometimes occurs today, they tried all sorts of different treatments, including calcium chloride, parathyroid hormone extract, and UV light, ultraviolet light, to try to treat this child. In addition, this case sort of illustrates some of the other features of the condition. They comment about how difficult it was to treat the Candida. They also comment about that her teeth had problems and didn't appear to have a lot of enamel. So we've obviously really progressed a long, long way, and there's been huge advances in our understanding of APS-1 since 1929, but we still really see as underlying it that there is this core triad of major contributory symptoms that we often see, including the chronic mucocutaneous candidiasis, often affecting the mouth, the rest of the GI tract and the nails, but can involve other places. The hypoparathyroidism, or the underactive parathyroid gland, and the Addison's disease, or the adrenal insufficiency. And these often occur within the first, we see them early on in life, particularly in the first 10 to 15 years. Of note, not everyone has to have all three, and there can be a variability in the presentation. But as well as these three classical features, there certainly can be many other systems involved, and what we'll hear a lot about today. So there are, in addition to the Candida, the hypoparathyroidism and the adrenal cortical insufficiency, multiple other targets that can be affected, including the thyroid gland leading to hypothyroidism, the pancreas leading to type 1 diabetes, and the either ovaries or the testes as well. In addition to endocrine targets, there are potential other features as well, in particular including the GI tract, involving either the stomach, where you can get gastritis or pernicious anemia, the lower intestine, further on in the intestine, causing this autoimmune enteropathy, or the liver as well. And now, as there's greater understanding, there's been more and more reports of these more rarer complications, including affecting the kidneys, the lungs, and in certain cases the nerves or the central nervous system. And so this just demonstrates the difficulty and the complexity in this condition, that it can affect many different sites across the body. So what is underlying it? And we're going to hear more about this in the next session as well. So we know that in APS-1, this represents that there are loss of function mutations in the autoimmune regulator gene, or the AIR gene. So what is the role of this AIR gene in the body? It's expressed in different sites, but in particular in the thymus. The thymus sits here just above the heart and has an important role in the immune regulation of the body. The thymus has an outer capsule, and then inside of it is the inner medulla and the cortex here. And in particular, what we're going to be, where the air gene particularly has a role, is in the medullary epithelial cells. So the thymus has a really important role in the body in trying to distinguish and regulate the immune cells in the body, and to try to help tell them what is self and what is not self. So the air gene has a critical role in this, and we'll hear more about this in particular tomorrow, and is thought through various mechanisms that it can regulate gene expression to be able to say if there a T cell or one of these immune cells is being self-reactive to parts of your own body, then it will get rid of it. However, and so therefore only those cells which are upregulated against foreign substances, such as to help fight infections, are then administered throughout the rest of the system. If you, however, have a gene change or a gene mutation in the air gene, then this interrupts this process, and we don't get the down regulation of those immune cells that should be normally turned off, which are activated against components of ourself, and this leads to autoimmune disease. So in this condition where there's a change in the air gene, this leads to production of multiple autoantibodies. In particular, in 2006 and onwards, there's been recognition that there's the hallmark antibody that we see in APS-1 are these autoantibodies against interferon omega and interferon alpha. And they seem to be really sensitive and relatively specific markers for APS-1. But there is a big diverse production of different antibodies, and this really underlines the diversity of the clinical presentation that we have. So for the classic triad, as we have at the top there, you can see antibodies that explain the candida, that's the CMC. We have antibodies against different interleukins. In the chronic hyperparathyroidism, which is the CH, you can have antibodies against the NALP5 and another thing called the calcium sensing receptor. And in Addison's disease, there's a whole lot of different adrenal autoantibodies that can produce. And as further research is going on, people are understanding and recognizing these different antibodies which are targeting different places in the body, and how best then it is for us to be able to screen and monitor these, and to be able to use them as markers for potential future complications or associations with the condition. But just like not two zebras have exactly the same stripes, we have there can be a very big wide spectrum in this condition. So as I talked about in our very first case, you can have two children or two members of a family who have exactly the same gene change, and yet they can present extraordinarily differently. And so us trying to get to understand what is it that's interacting between these genetic susceptibility to other environmental and susceptibility factors that causes this difference between the presentations that we see. So this presents us with challenges, but I also argue opportunities going forward as well. There are challenges around diagnosis and recognising it early. It's a complex disease. It can present in many different guises and many different forms. But trying to recognise it early, and particularly if we can avoid those potentially life-threatening or concerning presentations such as the low calcium or the adrenal insufficiency, are really important. There are challenges and opportunities around management in that we have multiple different systems that are involved and complex treatments that interact with each other and that all require monitoring. And how are the best ways that we need to be moving forward in monitoring for these associations and also monitoring for any side effects that may be associated with some of the medications we have to use. So we're going to hear more about the specific treatments throughout the day, but just really brushing very briefly again, doing the broad strokes on a couple of concepts. Obviously, the chronic mucocutaneous candidiasis can be very challenging to treat. For the oral presentation, it's really important that there's good dental care if possible and oral hygiene. Different antifungals are used for treatment, and often many children have to be on prophylaxis. In addition, there are specific therapies that are used for the actual nail candidiasis as well. We're going to hear later this morning from Dr. Weiner about the management of the endocrine manifestations. The idea is generally when there are hormone deficiencies that we replace that hormone, for example, with in the adrenal insufficiencies, in the hypothyroidism, if there is a ovarian testicular failure, or giving insulin in type 1 diabetes. Whilst the exception currently, although it certainly may well be changing, is with hyperparathyroidism. Here instead we're often trying to give back what the parathyroid hormone would normally do, giving active vitamin D analogues and calcium supplementation. But all of these is easy to say in principle, but can be challenging to achieve. And in particular, like in the case I illustrated to begin with, I think one of the really interacting and complicating factors for these patients is the autoimmune enteropathy, where absorption of medications can really then become very complicated, turning a relatively one-off diagnosis into a much more complex interplay of interactions. So people have used, and there have been various different reports of using immunosuppressive therapies in these patients. The reports have been used in different children of different ages, right from 2.9 years, which is Miss Julia, all the way up to older ages as well, and for different indications. Different therapies have been tried, and obviously trying to understand better about which therapies are the best indications and which situations they should be best used is an area of, I think, ongoing research and thought. So overall, the burden of APS or APSED is large, and there was an interesting recent study from Finland looking at 26 adults with APS-1. And they characterised and looked at what are the different burdens and challenges that these families do have to face, including all the different sort of features that they have and the uncertainties that go along with this condition as well. They did recognise that because of this, it does affect, potentially the quality of life, and that there are decreased measures of health and emotional well-being. However, these I think, present moments of opportunity and chances that we can therefore look and understand this better and seeing where are the opportunities that these families need extra support going forward. So this really brings back to the importance of coordination of care. These families have often multiple subspecialists who are following them, from endocrinologists, gastroenterologists, immunologists, dermatologists, dentistry, on and on and on. And how do we then really coordinate this so that the families aren't really feel like that they're going to multiple individual appointments, but how instead can we coordinate this so this is an interlocking puzzle rather than individual pieces not talking to each other? So where's the future going and what's next? We have, like we reflected, things have hugely changed from 1929 when they first recognised this condition to where we are now, and the ongoing research, I think, offers lots of promise and hope with where this condition is going. I think there are lots of future directions which need to be still undertaken to improve the care of this condition. Better understanding of this interplay between genetic and other susceptibility factors to understand why some children present with a particular clinical presentation compared to others. Really looking at ways of improving rates of early diagnosis and monitoring for associated features to reduce circumstances which may put patients at increased risk. And in particular, looking forward, looking at ways of new treatment modalities. So not so much just immunosuppression, but immunomodulation, where we actually can reduce the antibodies or the effect of this disease and maybe even reverse some of the effects. So there are certainly challenges, but there are, I'd like to reflect, opportunities, and having a symposium like this is a fantastic first step to really look forward about how we can move forward to address some of these ongoing challenges in the future. Thank you.